Free audio post-production by alphonic.com.
Today, what we're talking about is, I like these words, chrono-nutrition and it says chemotherapy, but it's chrono-immunotherapy.
Yes. Chronological, time-based.
Yeah. So what influence does time have on your nutrition? What we're talking about is following cancer treatment, like the role of the timing of when you eat and cancer fatigue. And then also when you get your immunotherapy, does the time of day you receive treatment make a difference?
Yeah. And I think this is something everyone should be talking about. Medical oncologists, the oncology nurses, the patients themselves. This should be all made common knowledge. So I'm excited to share some simple things to do to make sure you get the most out of an immunotherapy if you're receiving one. And then we could talk about the fatigue as well and how timing your meals may affect your fatigue.
So Tina, before we start today's episode, I think we should thank Amy, who is a new member of the Cancer Pod community.
Yay! Thank you, Amy, for joining.
Super exciting. Thanks, Amy, for joining our membership, which is through Buy Me a Coffee.
Yep. There's levels, $3, $9, $19, and you get more benefits with each one.
The top level, you get free swag. And the bottom level is kind of like, thank you, we support you, and we want you as a podcast to keep going. It's just kind of like, it's like a thank you. It's like a monthly thank you.
Yeah. Well, and they can join us on a YouTube Live with that as well. If there's specific
annually.
questions.
They get one live a year, and then the other levels, there's a quarterly live and a monthly live.
Mm-hmm.
So we really look forward to having more members joining. Supporting our membership helps us to keep bringing all the content that you all love, and you get to be part of the Cancer Pod community. How cool is that? Oh, and speaking of support and Buy Me a Coffee, Brandon, thank you. Glenda, thank you. And anonymous someone. You know who you are. Yeah.
We know who you are, and you know who you are.
Yes.
But
we're keeping it.
We will maintain your anonymity.
There you go. They all bought us coffees. So again, thanks for supporting the Cancer Pod. And then I want to read Brandon's, he left a little comment and it was really sweet. So Brandon says, love this pod. I listen to several integrative and functional medicine podcasts, and this duo by far offers the most reasonable, evidence-centered, and substantive health promotion material. Anyone personally affected by cancer will derive benefit from any of the 100+ episodes in their audio library.
I know, that was awfully sweet.
Very sweet.
It's interesting, contributions are awesome, but taking the time to actually write something, I'm like, oh, you took time. Like almost like time is more valuable than money.
He offered both. And I love when people leave us comments. Yeah. And so if you are listening on Spotify or Apple Podcasts or wherever you're listening, remember to give us a rating and to leave a comment, leave a review.
That would be great.
And that's how more people can find us.
Yes, it would be much appreciated because our whole goal is to reach as many people as possible. And as we grow, we, of course, are never satisfied. We want to grow faster and reach more people so we can help more people out. And our website also, I just want to say this, our website is also growing. So we're making sure that we post some of this information so that it's more readily available. And in 2025, our goal is to continue expanding on our blog space and our little storefront on there that has a few items that are useful for folks who are going through treatment or past treatment.
And then if this episode or if any episode that you've listened to makes you think of someone who would benefit, pass it along.
Yeah, that would be great. Just share it with someone you think this might be useful for. And that's all we ask, really. I mean, if you could do that, that would be excellent because, again, our whole goal is just to help people out. And a whole lot more people than we can help one-on-one, right? So right now, the thousands of folks who listen to us, it's kind of nice, We might never meet them, but we know we're helping people. So that is, at the end of the day, all that counts.
So share the podcast, spread the word, and thanks for being here with us, the Cancer Pod.
I'm Dr. Tina Kaczor.
And I'm Dr. Leah Sherman.
And we're two naturopathic doctors who practice integrative cancer care.
But we're not your doctors.
This is for education, entertainment, and informational purposes only.
Do not apply any of this information without first speaking to your doctor.
The views and opinions expressed on this podcast by the hosts and their guests are solely their own.
Welcome to the Cancer Pod. Hi, Tina.
Hey, Leah.
So today we're talking about timing and cancer, whether it's related to your cancer fatigue as a cancer survivor or whether it's related to when you get your treatment as a cancer patient.
Yeah. And at the end of the day, we can talk theoretically why things might be, but what we're going to be talking about are some papers that came out that show the timing of getting your immunotherapy, like what time of day, morning, afternoon, and evening, affects the response rate and whether you're likely to derive benefit or not. So that can actually be put right next to the other things that we know help people with their immunotherapies, right? So there's anything you can do that's non-toxic that may help you respond to treatment, I feel like is fair game if you can do it. So I would put timing in that category of easy things to do that give you a better chance of getting a good effect from your immunotherapy.
And fewer side effects.
Hopefully fewer side effects.
So you mentioned this study that we're talking about is specifically one, it's called the Effective Immunotherapy Infusion Time of Day on Survival of Patients with Advanced Cancers. And that was a meta-analysis.
Mm-hmm.
And so they looked at 13 studies.
Involving 1,663 patients.
That's a lot of patients.
A lot of patients.
So that's a good-sized study. And so they were looking at the relationship of the time of day that they received immune checkpoint inhibitors and how it affected their cancer progression, whether it was progression-free survival or overall survival. I think those are the two key points they were looking at. So, let's talk about what they mean by immunotherapy and then specifically these, immune checkpoint inhibitors.
Yes. So immunotherapy is exactly what it sounds like. It's a therapy that works with your immune system rather than just chemotherapy, which is directly toxic, cytotoxic, cell toxic, right? So immune therapy or immunotherapy means that it's affecting your immune system in such a way as to allow your immune system to see the cancer and attack the cancer the way it was supposed to do it in the first place, ultimately, right? So usually cancer tumors arise because there is a glitch, a way that the immune system is told to stand down and not recognize the tumor. So what are called checkpoint blockade, checkpoint inhibitors. These are those commercials. If you're watching TV, you see for Keytruda or Opdivo. Those are common commercials out there right now. Those are called checkpoint inhibitors. And a checkpoint is exactly what it sounds like. It's a point where the tumor normally says to the immune system, stand down, don't attack me. So when you inhibit that or you block that signal, now the immune system gets to go ahead and attack the tumor. So checkpoint inhibitors, checkpoint blockade, you're basically removing that stand down order that the tumor is normally giving to the immune system. That's the simplest way I think I have to explain it.
Yeah. And so some of the other words, you mentioned a couple of the immunotherapies that people may be familiar with, but you may have also have heard things like the PD-1 inhibitors, PD-L1 inhibitor. Also, there's a CTLA-4 inhibitor. Those are all words that patients may have heard.
Mm-hmm.
So that would make it more familiar. Yeah.
Those are all checkpoint inhibitors. Yes.
Yeah. And so the names of the medications are usually the ones that you look at and you're like, I can't pronounce that.
Yes.
But they like the generic name, but they do come up with clever names like, Yervoy and Keytruda, like you were saying.
Yeah. So yes, the generic names like ipilimumab or nivolumab. Those may be becoming more familiar as we head out of the patented names and into generics. But yes, no matter what, if it's a checkpoint inhibitor, what you're doing is you're overcoming a stand down order. I call it that because it's a really looks a little more complicated than that when you look at it in pictures and if we really got into the weeds of it. But that's all you need to know is that your own immune system is unleashed. That's the best part of immunotherapies. What I love about immunotherapies is not just that we now have much better therapies to offer people with lung cancer or metastatic melanoma, among other cancers, renal cancers, bladder cancers, all sorts of different tumors out there. It's also, in some ways, a way to unleash your natural tendency to attack the tumor. One of the side effects of that, of course, is that if you are unleashing the immune system, it goes too far and begins to attack other normal tissues. So the biggest issue with toxicity with these checkpoint inhibitors is that you end up having normal tissue also being attacked and what looks to be a lot like an autoimmune reaction, right? So you might have colitis or thyroiditis or all sorts of different ways that we could have the immune system unleashed too generally, in which case they have to calm it down with something that suppresses your immune system, and that would be something like steroids. So it's a balance. It's a fine balance.
Yeah, I was gonna pop in and say that it's not a toxic-free treatment, for sure, but a lot of the side effects can be, managed.
Yeah, and I just want to say that on the because it's integrative medicine podcast, I just want to say in the grand scheme, if someone's getting one of these treatments, we're going to go into detail about the timing, but there is already evidence that things like regular exercise, eating a very colorful diet, ensuring your vitamin D is normal in the normal range on your blood work,
eating a fiber-rich, fiber-diverse diet.
Absolutely. Yeah, so the diversity of your gut microbiome has a lot to do with whether you respond to these treatments or not. So we've talked about that in other episodes, but there's clear data that when people get an antibiotic just before going on one of these checkpoint inhibitor immunotherapies, they don't respond. They're less likely to respond than if they have a nice, diverse gut. So if you can not be taking an antibiotic just before you get onto one of these drugs, that's the ideal scenario. And there's a couple things to avoid. So minimize and avoid use of the antibiotic, like I just mentioned. And the other thing that came up was cannabis. Cannabis seems to lead to less effective immune checkpoint blockade agents. So
yeah, that's really interesting. We still have been promising that we're going to do an episode talking to an expert, a cannabis expert. So
still on our to-do list.
Yeah, it's still on our to-do list, but things are changing because like all the information is changing. Mm-hmm. So yeah, I think that's a really interesting and important point that it is still a relatively new field. And so, yeah, just taking caution. Just don't be like, oh, well, so-and-so took it for their chemotherapy. It's immunotherapy is a new field. Like,
yeah,
we still don't know.
Yeah. Yeah. And the thing about watching studies about recurrence or overall mortality is years have to go by in order to recruit for the study, watch the study, and literally watch a population over time. So it, by its nature, takes time to gather the evidence in any direction. All right, back to the study.
Yeah, so with this study, there was some criteria. It was in patients who had solid tumors, not any patient that had anything like leukemia or lymphoma. Everything was a solid tumor, and that the patients also had good performance status.
Right. Performance status is something we as clinicians use as a standard way of putting in the chart how someone is doing in their quality of life. So a classic system is the ECOG system, performance status of 0 to 5 ultimately, but 0 means they're fully active. That's great. There's no compromise. 1 is they're slightly symptomatic. They might have some side effects. They might be restricted to not be able to, run up a set of stairs, but ultimately they walk into an outpatient office, no problem.
They're able to go to work. They're able to do their day-to-day.
Yeah. So no life restrictions. They might be feeling less than stellar, but not life restrictions. And then 2 is they're symptomatic to some extent. They're in bed for less than 50% of the day, capable of all self-care. 3 is a little worse. Symptomatic. They're in bed more than 50% of their waking hours, but they're not bed-bound. So they're capable only of limited self-care, confined to bed or a chair, 50% or more of waking hours. And then performance status of 4 is bed-bound, completely disabled, cannot do any self-care, and they're confined to their bed or a chair for the day. Performance status is something that people will see in their charts. They might not know what it means, but now you do.
And then what's 5?
5, you're no longer with us.
That is so weird that they would even have a performance status for deceased.
It's interesting. I wasn't even going to mention it. Yeah. Because I was like, well, I've never seen it. I don't think it's like relevant.
It's it just seems weird that they would have, yes.
Yeah.
So anyways, yeah. So for this study, they looked at studies of patients who were performance status 0 to 1.
Yes. So these are people who are relatively healthy, at least healthy looking. They might not be feeling 100%, but they're doing well in the grand scheme. So they're relatively healthy individuals getting immunotherapy.
But what I've found super interesting about this study is that there are different parts of our immune system that at different times of the day are more active.
Mm-hmm. Yeah.
Like that's not something that somebody would think about in your day-to-day life. You're not thinking like, oh, well, this part. And it's not like, oh, your immune system in general is more active. It's like, no, there are different, lymphocytes that are active at different points in, your circadian rhythm. Like, so your circadian rhythm isn't just like your sleep wake, like, oh, I'm going to sleep, I'm waking up. It's your immune system is going to sleep and waking up at different times too.
Yeah. And the inflammatory state tends to be a little higher while we're sleeping, which is one of the reasons that pain seems to be more acute, or inflammatory pains in particular can seem worse when you're sleeping. As far as this study that we're talking about, that we already mentioned, the effect of immunotherapy infusion time of day on survival of patients, one of the studies, or some of the studies that they looked at, used a cutoff as their time of day because they knew that vaccines were less, how do we say it, stimulatory? A weaker vaccine response happened later in the day. So that has been established. So they consider weaker vaccine responses happen later in the day. So they speculated that perhaps that was true for immunotherapy too. Maybe later in the day we have less immune activity. And so that is what created the cutoff on the clock. Like we're going to consider later in the day, after 2 p.m. or after 4 p.m., for example. So it's pretty clear that there is a circadian rhythm, like you just said, to our immune system, and it's not functioning the same way all day long, which makes sense. I mean, cortisol is highest in the morning, and it goes down and it's lowest during the night. And cortisol is one of our natural anti-inflammatory hormones.
I always think about is like if you have a cold or if you have allergies, and then the sun starts to set, and you're like, why are my symptoms getting worse?
Mm-hmm.
And that's when I think of like, oh, that's the cortisol, right?
Yeah. Those circadian clocks that we have are absolutely fascinating because they have signals from our external environment, like light itself, light and dark, and fasting and feeding. Are you taking in calories? Are you not taking calories? Your body's reacting to all of that. And then there appears to be some that are completely independent of all exterior signals, and in our bodies literally know 24-hour rhythms, even without light, dark, fasting, and feeding, which I think is like kind of crazy. That's really neat. Like that our bodies could even sense time without any signals. Anyways.
So what is the study basically, or, showing? What is this meta-analysis showing?
So we mentioned most patients got a checkpoint inhibitor, almost all of them. And it showed that of the 13 studies that made up the 1,600 plus people, they pooled them. And early time of day groups had both longer overall survival, so they lived longer, and they had longer progression-free survival. And it was highly significant, like 50% longer on average and 50% more progression-free survival. So it wasn't just like a marginal amount, and every single study showed it. And I should also mention, I don't know if we said this already, but these were all retrospective evaluations. So they went back to the charts and looked at what time of day people received their treatment. So they weren't being told to come in later in the day or earlier in the day. There wasn't like a randomization. So just a little aside, it's just a retrospective review of the data. And the cutoff, if you want to be safe, I would put the cutoff looking at all of the data across the board at least 1 o'clock, if not noon. Every study has its own cutoff. Some say noon, some say 11:30, some say 2. I mean, they all differed, but certainly I would say just before noon seems to be a safe cutoff point to say, okay, you have a better chance of having a favorable benefit from your immunotherapy if you're in good health. That is a performance score of 0 or 1. 0, 1, maybe 2. Yeah. And you have to be relatively healthy in the first place.
Was there a study that showed 2?
The study that looked at people with a performance status of 2 and 3, they included people who were more ill in their study, found that those who were not relatively healthy, their quality of life was impaired, they were in bed most of the day, their performance score was more like 2 or 3, those people were the outliers in this scenario. Those people actually had better overall survival and better progression-free survival if they had their treatment later in the day. I don't know why that is. It's just what it is. Take it at face value. We could, speculate all day long. But to me, that just says, okay, if you really have a hard time moving, you're in bed most of the day, just go at your pace, right? It'd be hard to get to the infusion room by noon, probably anyways. So don't feel badly and don't make it happen if you're not feeling well enough. But if you're otherwise feeling decently, go before noon. If you feel not so great, maybe later in the day is better because it's a little less toxic later in the day. So toxicity varies with time of day.
And then, of course, all of this kind of depends on your infusion center, on when they're scheduling infusions and how long the infusion takes. And, some people are getting multiple medications. And so,
yes, there are
there are a lot more factors. Yeah, there
are some practical logistics you gotta deal with. But all else being equal, if you're relatively healthy, meaning you're walking in and out of your doctor's office and you're capable of self-care, then go before noon if you can.
So that's kind of the takeaway from that study.
I think so, yeah. And again, it goes under the why not. I mean, in my mind, I always have the why not column. It's certainly not going to hurt you. It could help you. And the data has been so consistent. 13 studies all showing the same trend and the same result is pretty convincing. None of those, it wasn't like we averaged out to be that time. It was like every study that looked at it saw the same thing. And that was earlier in the day, people fared better. So,
all right.
Doesn't hurt.
Okay, so when we come back, we're going to talk about the effect of time-restricted eating on cancer survivors.
On cancer fatigue, specifically.
Yeah.
All right.
The second article that we're going to talk about that has to do with timing is a study called Time-Restricted Eating to Address Persistent Cancer-Related Fatigue Among Cancer Survivors. And that was a randomized controlled trial. It was a really small study. I think they had 30.
Mm-hmm. Looks like it.
30 subjects that they looked at.
Mm-hmm.
Really small study. They looked at adult cancer survivors, and they were from 2 months to 2 years outside of treatment. It was okay if the person was still getting, what do they say, like a non-conventional chemotherapy? So they mean like immunotherapy. So if someone was on a maintenance immunotherapy, that was fine. But mostly they were looking at people who were outside of any sort of treatment, radiation, chemotherapy, or surgery. There were studies prior. This isn't like the first of its kind. There were other studies that had shown that there may be a role for time-restricted eating. Basically, time-restricted eating, we kind of covered this in our fasting episode, but it's when you allot yourself a certain time of day to eat. Well, you could do 12-hour period where you have a 12-hour eating window. People talk about like the 16-8, where you have an 8-hour eating window. This study looked at a 10-hour window. And so the subjects were able to pick what their 10-hour window was.
Okay.
And then everyone in this study had access to nutrition counseling.
Okay.
So whether you were participating in the trial or you were the control, everybody got individualized nutrition counseling, which is kind of cool.
So any 10 hours in a day they could eat, and the other 14 hours they were fasting.
Yeah, 10 consecutive hours. It had to be consecutive.
So 7 to 5.
Is that 10 hours?
Yeah. 8 to 6. Yeah. Whatever they're
okay.
Whatever
there you go.
Chose.
Yeah. Whatever they chose.
Okay.
Noon to 10. Whatever. Yeah. And so the way that they evaluated the fatigue, there were a couple of different tests that they used. They filled out initially, and then I believe it's 6 weeks and then 12 weeks. So there's the FACIT test, and that is functional assessment of chronic illness therapy, and it's specific for fatigue. And then there also is the brief fatigue inventory, which is a shorter test, and that's the BFI. And we can put links to those if people like taking tests to assess their fatigue levels.
Yeah. Well, can I interject there? I think it is good to take assessments because it's hard, because it's so subjective. So it's not a bad idea to kind of do it, or if you're helping someone, so you can share your fatigue on a more objective basis. I don't know. It would be nice because as a practitioner, I would use these kind of things to make sure that what we're doing is helping and that we're not deluding ourselves into thinking things are better or that they are worse or that it's just a bad day. It's going to look worse, or a great day. You're going to be like, I'm great today. And actually you're really fatigued.
I've seen that at the cancer center where I used to work, and it could be helpful because someone could be like, well, I don't know, is my energy's better than it was last time? And someone goes, well, last time it was a 7, and now you're saying it's a 5. So
it's all subjective.
Okay, so basically, long story short, it was found in this very small study that restricting eating did play a part in reducing their fatigue. So it did show benefit.
Mm-hmm.
What I didn't see is, and it may be in there specifically, to see like what were they eating? Were they just eating their regular diet? I don't know if it was in that study. If they talked about it, I mean, they're getting nutrition counseling,
right?
But yeah, what are they eating?
Yeah. It's a good question. I'm going to guess that they didn't eat anything too differently, or else the conclusion wouldn't be able to be made. It would be based on content, not just timing, right?
Right.
And according to their abstract, glucose parameters tended to be lower, and rest activity rhythms tended to indicate more regularity for those in the time-restricted eating group versus the control group. So that sounds like they had better metabolic systems, like their glucose was better controlled.
That's sort of like already been established in other studies about time-restricted eating, is that it does improve metabolic function. Okay, so for the control arm, the participants talked about their eating habits, and then they set goals based on their individual needs. And so they talked about macronutrient needs, different food groups, what their preferences were, so on. And they were told not to change the timing and when they ate their meals. And then in the 10-hour eating window participants, they were encouraged to have the eating window be more during the day and to stop it like a few hours before bedtime. It does say, aside from water, which was always allowed, only unsweetened tea and black coffee were allowed before the eating window, which makes sense.
Sure.
Calorie-free foods and beverages such as chewing gum and diet soda were not allowed outside the eating window, which is interesting. And then they also met with the nutritionist who talked about the goals that they were trying to achieve by eating within that window.
So the take-home is try to eat in a 10-hour window if you can.
Yeah. For cancer survivors, right? This was not for patients in active treatment.
Right. This is for cancer survivors.
For cancer survivors, yeah. Or if you're getting maintenance therapy, right?
Yeah. And I think eating in a 10-hour window is fairly doable for most people. I mean, I know people might have some hypoglycemia and other issues that they have to deal with, but if you can get yourself, you start at, 12 hours and then go to 11 and then go to 10, that kind of thing can be done. And I feel like it's part of a normal circadian rhythm, right? So this is what we're supposed to be doing on some level, is eating when the light is out and we're moving about, and fasting overnight. And that allows our metabolism, our endocrine systems, our hormonal systems, everything in us, our immune systems, to be in a normal, healthy rhythm. So I put circadian rhythm just as it's right next to exercise, right? Normalize your circadian rhythm, exercise, eat well. Normalizing your circadian rhythm means sleeping well and addressing that if you don't sleep well.
And there was exclusionary criteria, including anyone with a history of eating disorders. I don't believe you could be diabetic, but in general, time-restricted eating has been shown, as we've said, to help people with metabolic syndrome. Another thing about the exclusionary criteria is in this study, they had a body mass index of greater than 18.5. That is important so that you're not underweight. The other exclusionary criteria was there was no surgery planned during the study duration, And then the contraindications are insulin-dependent diabetes, if they are receiving enteral or parenteral nutrition, and then it says a recent history of an eating disorder, but I would say any history of eating disorder.
Mm-hmm. That makes sense.
But for the study, it says a recent history.
Yeah.
But yeah, I just think in general, anyone with a history of eating disorder should not do this on their own.
Yeah. Yeah. I agree. Anyone with a history of eating disorder should be working with professionals around eating, around diet. So, yeah, we have seen that go wrong. And it happens, we kind of attract that crowd in the naturopathic profession. We attract a crowd that will like to perfect their diet, which is why there is a term now called orthorexia, which is not a formalized diagnosis, I don't believe, but orthorexia is a term for people who would like to eat perfectly. And so I think that sometimes we can get ourselves into a bit of a bind trying to choose the perfect diet. And people who have a history of eating disorders are more likely to fall into that, feeling like they can't eat perfectly all the time.
So if this is something that a person is interested in doing, talk to your dietitian at the Cancer Center, or there now are programs where you can have virtual meetings with dietitians and trained nutritionists. So that's kind of interesting too. But yeah, 10 hours is doable. And I probably would tell people, because I know that 16-8 was really popular for a while. And we may have mentioned it in the fasting episode. I don't find that women do well on that extended, fasting period. So I think, the 10 hours, I probably wouldn't do more of a fasting window than 10 hours.
I don't think so either. I think that that's normal, right? That's still within the bounds of a normal day to eat between 8 a.m. and 6 p.m., for example.
Yeah. I mean, looking at myself, it is really hard because I like to eat when my husband gets home. And usually that means that the minute he walks in the door, I'm like, okay, sit down and eat. Right. So it's not always possible. And then that forces me to push my breakfast later. So
yeah.
So there, you kind of think about that. Or that, sometimes someone's like, well, I'm going to be going out to dinner with friends and it's going to go late,
Right. So it depends how you frame it, right? Because a 10-hour eating window is the same as a 14-hour fasting window.
Right. What I'm saying is that it may not always be consistent,
right?
Because it may have to change,
right?
Depending on what is going on.
Yes. So if you go out with friends and you end up eating at 8 p.m., you might have to wait a little longer the next day to make 14 hours. Yeah.
Right.
Yeah. Absolutely. That's the beauty of it. It can be kind of fluid.
Yeah, unless you have like 2 different events. If you have an early morning breakfast meeting the next day. But
nobody's perfect.
Nobody's perfect. And if it doesn't work every single day of the week, that's fine too.
Exactly.
But I thought it was interesting that helped to reduce cancer-related fatigue.
Yeah, and it's so simple, It's such a simple thing to do, to adopt.
I like your idea of starting with a 12-hour window and then going to a 13-hour fasting window and then increasing it slowly. I mean, I find a 13-hour window, which is what I typically do, a 13-hour fasting window, not an eating window. That seems to be really easy. I have been kind of pushing it, to see how much longer I can go. But I'm a breakfast person. I like to wake up and have breakfast.
Oh, you do?
I love breakfast.
Oh, okay.
I love lunch and I love dinner. So I really like, oh, what am I going to have for breakfast this morning? That kind of thing.
Oh, wow. Yeah.
I think about food a lot.
Yeah.
When I do the Prolon fasting mimicking diet, by day 3, I'm looking at cookbooks and recipes online. I'm planning what I'm going to be eating
when it's done. Wow.
Oh, yeah.
Yeah, I don't think about food very much. You wouldn't know it to look at me, but I don't.
So interesting.
No.
Yeah.
No,
I'm big into that.
I could do a couple meals a day, 2, something around 10, something around 3, and I'd be done. I don't do that because, I have a partner, we have 3 square, but
wait a minute. You can have your last meal at 3?
Yeah, I often have my last meal 4 or 5, so 3. Ideally, when I'm alone, I eat pretty early and then I'm done for the night.
Oh my God. I would have a blood sugar crash in the middle of the night and wake up.
Yeah.
Fascinating.
All right. Well, the take home in summary.
Take home.
Or as AI likes to say, in conclusion.
And in conclusion, talk to your doctor if you want to try any of these changes in timing.
I think you could try to institute this on your own.
Oh, for sure.
Yeah. I mean,
I was just being like a commercial.
Yeah, I know.
Well, the thing with, the immunotherapy, you might have to talk with your doctor, depending on.
If you're already getting immunotherapy, you don't have to really consult to say, can I get it in the morning? Do you?
I think it depends on when doctors are around.
Yeah. Well, yes.
Scheduling at hospitals,
Yes, the practical part, the logistics part, but not for their
That's what I'm
permission
saying.
per se. I wouldn't.
Anyway.
But that's me.
I know. I'm just talking about the logistics part.
Yes, logistics, yes. Permission.
I don't need your stinking permission.
I don't need your stinking permission to do the best thing for me.
So on that note, I'm Dr. Leah Sherman.
And I'm Dr. Tina Kaczor.
And this is the Cancer Pod.
Until next time.
Thanks for listening to the Cancer Pod. Remember to subscribe, review, and rate us wherever you get your podcasts. Follow us on social media for updates. And as always, this is not medical advice. These are our opinions. Talk to your doctor before changing anything related to your treatment plan. The Cancer Pod is hosted by me, Dr. Leah Sherman, and by Dr. Tina Kaczor. Music is by Kevin MacLeod. See you next time. God.
I'm going to hit the button.
Free audio post-production by alphonic.com.